So today we shall going to discuss drugs used in congestive heart failure. Heart failure is a very common condition nowadays, and ultimately the patients suffering from the hypertension or ischemic heart disease or arrhythmia can succumb to the heart failure. So we need to know classification of the heart failure, signs, symptoms, and how heart failure is diagnosed. What is the pathophysiology and what is the response to heart failure, treatment strategies, and pharmacotherapy of heart failure, and what are the recent advances. So, what is heart failure? Congestive heart failure or plain heart but simple heart failure is a condition where heart is unable to pump sufficient blood to meet the metabolic demands of the body. That means it is unable to pump sufficient blood to meet the metabolic demand of the other organs, or able to do so only with elevated filling pressure. And this is the compensatory response during heart failure. If you understand this, then you can understand how we can reverse the pathophysiology of the heart failure. So when there is heart failure, that means heart is unable to pump adequate blood. So there is decreased force of contraction, decreased cardiac output. So there is and this causes body to have some compensatory mechanisms. And one of them is increased sympathetic discharge that will cause vasoconstriction and beta 1 receptor activation. Vasoconstriction will lead to increased preload after load, and beta 1 activation will cause increased force of contraction and heart rate. So that there is body tries to send more blood to the other organs by causing sympathetic discharge, and too much vasoconstriction will also cause cardiac remodeling. And when there is decreased renal perfusion, as per the previous class of renin-angiotensin system, when there is decreased renal perfusion in heart failure, there is increased renin release from the GG apparatus, and also decreased renal perfusion will cause decreased glomerular filtration rate. When there is decreased renin release, that will cause increased activation of the means formation of the angiotensin 1, angiotensin 2, and ultimately angiotensin 2 by acting on the AT1 receptor on the zona glomerulosa, it will cause increased aldosterone release, and increased aldosterone release also cause cardiac remodeling, also salt and water retention by aldosterone effect as well as angiotensin 2 effect, and also decreased GFR. Also that means there is sodium and water is retained. So as a result of this cardiac remodeling, there is back pressure and edema, and also there is ventricular dilation, and this due to this cardiac remodeling, there is further decrease in the force of contraction and cardiac output. So this is the vicious cycle of the heart failure. When there is decreased force of contraction, cardiac output is trying to maintain the cardiac output by causing increased sympathetic discharge as well as increased activation of the renin-angiotensin system, but ultimate result is of this activation is cardiac remodeling, which will further decrease the force of contraction as well as cardiac output by ventricular dilation. So this is the classification of heart failure by ejection fraction. It can be reduced ejection fraction. That means normally we have ejection fraction is around 60% or above, but when it is reduced below 40%, then we call it systolic heart failure. Preserved ejection fraction is 40 to 50%, and there is also so commonly we the newer classification says that if heart failure left ventricular ejection fraction is less than 40%, then it is called heart failure with reduced ejection fraction, HFrEF, heart failure with reduced ejection fraction. When there is heart failure ejection fraction is more than 50%, then we call it as heart failure with preserved ejection fraction, HFpEF. And if it is between 40 to 49%, then we call it heart failure with moderately reduced ejection fraction, that is called HFmRF, moderately reduced ejection fraction. And also this can be acute and chronic, and anatomically it can be left-sided or right-sided. Signs and symptoms, you have to remember few of the important signs and symptoms. One is of course dyspnea, and there is ascites, there is dependent or pitting edema, there is decreased oxygen saturation, it can cause confusion, jugular venous distension, it can cause tachycardia, fatigue. So remember three cardinal symptoms of the heart failure, signs of the heart failure. One is jugular venous distension, elevated jugular venous pressure, there is tender hepatomegaly, and there is ascites or pitting edema. There is ascites, no, there is dependent edema in the dependent part. This is the edema, tender hepatomegaly, and jugular venous pressure elevation. These are the three cardinal signs of the heart failure. Now, how heart failure is diagnosed? Of course, medical history is to be taken to reveal symptoms, and examination is done What tests need to be done? Chest X-ray, because often you can find cardiomegaly, and there is a blood test to determine whether heart failure is present or not. We can do a test like testing of the brain natriuretic peptide, that is called BNP. In heart failure, BNP is elevated. We can do ECG, you can do echocardiogram to classify the heart failure, whether it is preserved ejection fraction or moderately reduced ejection fraction or reduced ejection fraction. Indicator of diagnosis of heart failure. So ejection fraction is the percentage of the blood that is pumped out of your heart during each beat. So ejection fraction determination is very important for proper therapy of the heart failure. So what is the diagnostic criteria? There must be presence of some symptoms and signs. If it is between 40 to 49%, it is called moderately reduced ejection fraction. If it is less than 41%, we call it a heart failure with reduced ejection fraction. If it is more than 50%, we call it heart failure with preserved ejection fraction. Also, there should be elevated levels of the natriuretic peptides, that is B natriuretic peptides, brain natriuretic peptides, and at least one additional criteria like structural heart disease or diastolic dysfunction, and there can be this should be present if it is moderately reduced or preserved ejection fraction. So when left ventricular ejection fraction is less than 40%, then heart failure is stamped, then no other indicator is needed. But when there is heart ejection fraction is not so much reduced, like 40 to 49% or less than 40%, then additional features like elevation of the brain natriuretic peptide, that is also needed to stamp the diagnosis of the heart failure, and also there should be a diastolic dysfunction. So here look, BNP should be level in heart failure, it is more than 35 picogram per ml, or there is another indicator NT, that is the N terminal pro BNP, that level should be more than 125 picogram per ml. So BNP or NT pro BNP measurement is important for diagnosing the heart failure. So once again, this is the picture. So clinical symptoms must be present, natriuretic peptide may be elevated, and if it is clinical features and natriuretic peptides all are elevated, then we call it a, if clinical features like history of the coronary artery disease, arterial hypertension, use of diuretics is there, and presence of some edema, jugular venous dilation, also hepatomegaly is present, then we have a great suspicion of the heart failure. We then check the natriuretic peptides, and if it is elevated, then we are further sure that it is a heart failure. If it is not elevated, still we can do it. You cannot do, if there is no facility, then you can directly do echocardiography. But ideally, if clinical feature is present and if natriuretic peptide is elevated, then heart failure is stamped. Echocardiography is done to classify the heart failure, whether it is preserved ejection fraction or moderately reduced ejection fraction or reduced ejection fraction. So once again, the pathophysiology, systolic heart failure. So there is reduced cardiac output, and there is increased cardiac filling pressure, and activation of the RAS, renin, angiotensin, aldosterone is activated, and aldosterone causes cardiac remodeling. Also angiotensin 2 by salt and water retention, and also vasoconstriction, that will also lead to the increase in the cardiac filling pressure. And aldosterone, as well as aldosterone causes sodium and water retention, that will further increase the cardiac filling pressure, and this will ultimately causes cardiac remodeling and reduce cardiac output. So this is the net effect of the renin-angiotensin activation. So the angiotensin 2 by causing peripheral vasoconstriction, it will causes increase in the afterload and cardiac output, and aldosterone secretion is enhanced by the angiotensin 2, that will cause salt and water retention. There is increased plasma volume, increased preload, and increased cardiac workload, that will aggravate the heart failure. And also salt and water retention causes increased edema. So what is the treatment strategy of heart failure? So if you remember the previous and the first chart of compensatory mechanism, we can understand how we can decrease the symptom or decrease the reverse the pathophysiology of the heart failure. So one is, of course, there is edema, there is salt and water retention, so we can use diuretics to control the symptoms. So high ceiling diuretics are preferred, like furosemide, bumetanide. In less severe case, we can use thiazide diuretics, hydrochlorothiazide, metolazone. Inhibitors of the renin-angiotensin system, that is more the cornerstone of the therapy. So AC inhibitor, enalapril, enalapril, or ARB can be given, like telmisartan, valsartan. So what is the role of AC inhibitors? AC inhibitors will decrease the activation of the angiotensin 2, and will further decrease the chance of those vasoconstriction and aldosterone overactivity, and ultimately it will lead to decrease in the cardiac remodeling. Also, you can use beta blockers because there is sympathetic activation which is causing beta 1 activation and also vasoconstriction, and that will lead to increase in the preload and afterload that is not needed actually in heart failure. And also increased heart rate means there is more oxygen demand of the heart. And beta 1 receptor activation, it has been found that beta 1 receptor also presents responsible for the release of the renin. So if beta blocker is given, then renin release is also inhibited, and ultimately angiotensin aldosterone system is also inhibited, so there is decreased cardiac remodeling. And aldosterone antagonist directly we can use if there is too much salt and water retention and ejection fraction is very less. We can use aldosterone antagonists like spironolactone, eplerenone, and neprilysin inhibitors, sacubitril. That I shall discuss later. So these are the 5 major drug groups. Also, there is some additional drugs like bevbradine that can be used, but these are the 5 major cornerstone of the major drug therapy of the heart failure: diuretics, ACE inhibitor or ARB, beta blockers, aldosterone antagonists, neprilysin inhibitors. Next, we can use some vasodilators like glyceryl trinitrate hydrolyzine, inotropic drugs, digoxin, digitoxin, oben, sympathomimetics like dobutamine, dopamine, that is used only in the acute setting when patient is severely symptomatic with very reduced ejection fraction, phosphodiesterase 3 inhibitor like amrinone, and metabolic cardioprotectives we can use like bevbradine, trimetazidine. So these are the treatment of heart failure, drugs available for the heart failure. Now we shall discuss one by one. So cardiac glycosides, though it is grouped in the inotropic drugs, and in your books you have to read it in detail, but cardiac glycosides are not very commonly used drug nowadays. Previously it was the mainstay of therapy, but nowadays with advent of the diuretics, ACE inhibitors, beta blockers, cardiac glycoside use has been diminished. So what is the cardiac glycoside? It is if a sugar molecule is joined together with a non-sugar molecule by ethyl linkage, it is called a glycoside. So sugar and non-sugar molecule attached by ethyl linkage, that is called glycoside. So example of sugar is digitoxose, and non-sugar is a steroidal lactone. Steroidal lactone has that ring, cyclopentoparhydrophenanthin ring, and this will together will make the cardiac glycoside. So leaves of the digitalis lanata provide this molecule. This is obtained naturally. Digoxin and digitoxin. Leaves of digitalis purpurea or the foxglove are the major source of digitoxin. So digitalis lanata and digitalis purpurea, these are the two sources of the cardiac glycoside. From digitalis lanata we derive digoxin, and digitoxin can be obtained from the digitalis lanata as well as digitalis purpurea. Also there are two other agents which can be called cardiac glycoside like strophanthus G or auben. So this is the foxglove tree, that is the digitalis purpurea, from which you can have digitoxin, though commonly dioxin is used. So chemistry of the cardiac glycosides like aglycone, which is responsible for the pharmacodynamic activity, it is the steroid nucleus, cyclopentoparhydrophenanthin ring, and lactone ring is attached to them, and there is sugar residue, sugar that influences the pharmacokinetics. So together it is cardiac glycosides. Attached sugars modify the solubility and cell permeability, and in general, glycones have less potent and short-living action. Aglycone is consisting of the cyclopentanoparhydrophenanthin ring, to which attached 5 or 6 membered unsaturated lactone ring. So now you have to understand the mechanism of action of the digitalis of the cardiac glycoside. So look here. So this is the normal cardiac myocyte, and there is a sodium potassium ATPase pump, and there is sodium calcium exchanger, and in the inside there is a sarcoplasmic reticulum where calcium is stored. Now normally what happens? Normally with this help of sodium potassium ATPase pump, that is an active pump, normally this is an active pump. So when normally it will drive out 3 sodium outside the cell, and it will give entry of 2 potassium channel ion. So 3 sodium is exited, 2 potassium gets entered, and it is an active pump. That means though normally we have more intracellular Normally sodium concentration is less inside, potassium concentration is more outside, is more inside. So despite this concentration, it is going into against the concentration gradient. That means though sodium is higher outside, it will cause higher sodium exit against the concentration gradient. That's why it is called active pump. So normally 3 sodium is entered and 2 potassium is 3 sodium is get out, it is exited, and 2 potassium gets entered, despite potassium concentration is higher inside. So this is active pump. When there is an activation of the sodium potassium ATPase pump, 3 sodium gets out and 2 potassium gets in, and after this there is the activation of the sodium calcium exchanger, and under this influence, as the sodium concentration little bit falls after this sodium potassium ATPase activity, so sodium calcium exchanger tries to keep the balance back, and that's why there is sodium calcium exchanger there, that will cause sodium entry and calcium out exit, and this is a normal phenomenon. But when lethal is given, they bind to the sodium potassium ATPase channel and blocks it. So there is therapeutic dose leads to partial inhibition of the sodium potassium ATPase channel. So intracellular sodium is remains inside. So sodium is not exited. That's why sodium calcium exchanger is also not activated. So sodium calcium exchanger is activated only when there is activation of the sodium potassium ATPase pump. So normally sodium calcium exchanger will cause calcium get out and sodium to get in, but as this doesn't happen, so calcium remains inside the cell. So there is part inhibition of the sodium potassium exchanger also, that will cause increased concentration of the calcium inside the cell, and this will cause further entry of the calcium, and this will lead to further release of the calcium from the sarcoplasmic reticulum. So this is an paradox. So calcium, intracellular calcium more, that will actually invite more calcium, and from the outside as well as inside from the sarcoplasmic reticulum, and this calcium will act on the troponin, and there is more binding of the actin and myosin, that will cause increased cardiac contractility. And this calcium inside, and so sarcoplasmic reticulum will have a larger store of the calcium that is released when there is increase in the intracellular calcium. And this sarcoplasmic reticulum, that is a one, it has a channel that is called ryanodine receptor, which is causing this calcium efflux from the sarcoplasmic reticulum into the cytoplasm. And also there is an on channel that is called sarca, that is after this action is over, they take up the remaining calcium into the sarcoplasmic reticulum back again. So there are two receptors available in the sarcoplasmic reticulum. One is called ryanodine receptor, RYANODINE, ryanodine receptor, which is causing calcium efflux from the sarcoplasmic reticulum to the cytoplasm. And after the actin myosin interaction is over, the SARCA receptor, SARCA, ACRCA, SARCA receptor will take up the, and not receptor, SARCA channel will take up the excess remaining calcium channel back into the sarcoplasmic reticulum. So this is due to this mechanism. So sodium potassium ATPase is inhibited, sodium intracellular concentration is high, that will lead to inactivation of the sodium calcium exchanger, and that will lead to excess calcium in the intracellularly, that will invite further calcium from the outside as well as from the sarcoplasmic reticulum, and this excess calcium in intracellularly will cause excess binding to the troponin, and there is more actin myosin interaction, that will cause cardiac contractility to be increased, which is low in heart failure. That's why it is called positive inotropic action, due to as it increases the contractility of the heart. So remember this side mechanism action of the digitalis. So ultimate result is force of contraction is increased. So pharmacokinetic, there are some difference between the dioxin and digitoxin. We commonly use dioxin. Plasma binding is very high for the digitoxin, so effect persists longer. Onset of action is also rapid for the dioxin, 15 to 30 minutes. Duration action 2 to 6 days for dioxin, 2 to 3 weeks for dioxin. So dioxin and dioxin, though it is a commonly used cardiac inotropic drug, positive inotropic drug, it has lots of adverse effects, and it is also very prone to cause toxicity because it has a narrow therapeutic index. So when dioxin toxicity occurs, it is difficult to treat, and as duration action of detoxin is very long, that's why adverse effect tends to go off slow. That's why dioxin is not preferred. Plasma T have dioxin 40 hours, dioxin 5 to 7 days. Elimination, dioxin is mainly eliminated by kidney, dioxin mainly eliminated by liver, and daily maintenance dose 0.125 to 0.5 milligram for dioxin. So administered dioxin and dioxin commonly both are given orally. So remember the difference: onset of action, duration of action, plasma T have all are long for the dioxin. So what are the pharmacological actions of the dioxin or cardiac glycoside? There is increased force of contraction and cardiac output, but there is decreased heart rate. This decreased heart rate is due to the vagal effect. So dioxin has some vagomimetic property, and as vagus decreases the heart rate, dioxin also decreases the heart rate, and it has some unique property. That's why it can cause arrhythmia in different tissue. There is decreased refractory period and increased conduction velocity in the atrium and ventricle, but there is increased refractory period and decreased conduction velocity in AV node. So in AV node, they causes decrease in the conduction velocity. That means these are the drugs which is used in the treatment of the atrial arrhythmia, like atrial flutter, atrial fibrillation. So that in because when rhythm is generated from the extra rhythm is generated from the atrium, they tend to go to the ventricle. But if AV node filters the most of the impulse, then ventricle will have less uh, pressure. That means in ventricle they will receive less impulse, and that will be beneficial for the heart. That's why for atrial flutter and fibrillation, dioxin is very good drug, because they will then avinodal conductivity is decreased, avinodal refractory period is increased. That means most of the impulse generated from the atrium will not reach the ventricle, and heart will have some rest. But in atrium and ventricle, that means impulse generated within the ventricle, then it will cause further increase in the conduction velocity. And so if it is used in ventricular arrhythmia, then it will further increase the conduction velocity and it will aggravate the ventricular arrhythmia. That's why dioxin should be used very cautiously during arrhythmic state. If it is atrial flutter fibrillation, then it is a very good drug. But it is if arrhythmia involves the ventricle, then it can be further damaging because of the differential property in the of the refractory period and conduction velocity in the different tissues. And there is increased automaticity of the SA node, AV node, and there is the increased automaticity is present in the not in SA node, AV node, is that it is in the ventricular tissue extra. So that is also called idioventricular rhythm. So increased automaticity means it will generate its own impulse. And ECG, there is increased PR interval and decreased QT interval. Increased PR interval is due to this increased refractory period in the AV node and decreased QT interval. So the both can give rise to arrhythmia. Increased PR interval can cause bradyarrhythmia sometimes, and decreased QT interval can cause tachyarrhythmia. So that's why dioxin, though it is a very good inotropic drug, but because of this potential for developing different arrhythmias like tachyarrhythmia, bradyarrhythmia, its use has been restricted. Now, so there are some extra cardiac effects. So kidney, due to improvement in the circulation and renal perfusion, there is gradual elimination of the salt and water. So when there is patient is receiving dioxin, cardiac contractility is improved. So perfusion to other organs that was decreased in the heart failure, that is gradually improved. So renal perfusion improves, that will lead to improving the GFR. That will causes more excretion of the salt and water. Decrease in heart rate, this is due to increased vagal tone, decreased sympathetic overactivity due to improved circulation, and also there is direct action of the SA and AV node. So mainly due to increased vagal tone, and also due to decreased sympathetic overactivity due to improved circulation, because circulation is also peripheral circulation. If it is improved, then also that will also cause decreased sympathetic stimulation, and that will further increase that will decrease the heart rate, and that is beneficial for the heart at this time. Systole is shortened, diastole is prolonged. So whenever heart rate is short, heart rate is slowed down, there is relatively more prolongation of the diastolic period, and systole is shortened, and ventricles more completely emptied due to forceful contraction. So though heart rate is slow, but with each beat ventricle is emptied better, that will cause increased perfusion. So ventricles are more completely emptied due to forceful contraction. So what are the uses of dioxin? It is congestive heart failure and cardiac arrhythmia, arterial fibrillation, atrial flutter, main and supraventricular tachycardia. That means arrhythmia generating above the ventricle, it will have a very important role because it will filter the most of the impulse from the atria to reach to the ventricle, because it increases the refractory period of the AV node. Adverse effects, we have to remember, nausea vomiting is first to appear. Also, it can cause some visual disturbance. There is some yellow shadow in the, there is yellowish discoloration of the visual field often. And endocrinal, it can cause gynecomastia, it can cause bradycardia, pulsus bigemini, atrial extrasystole, flutter, fibrillation, and ventricular extrasystole, tachycardia, fibrillation. Both all can happen with the dioxin, and it can cause, it can convert partial heart block into the complete heart block. So treatment of toxicity, usually stop is the initial step, and we can give oral or parenteral potassium supplements. So it has been found that sodium potassium ATPase, the channel is dioxin inactivates. That is, so this dioxin effect is enhanced when there is hypokalemia. So in presence of hypokalemia, dioxin binds to the sodium potassium ATPase channel better, and that will cause further inhibition of the channel. So dioxin toxicity is enhanced with hypokalemic states. That's why hyperkalemia is, if it is created artificially by giving potassium supplement. So in hyperkalemic state, dioxin cannot bind to the sodium potassium ATPase channel sufficiently, so dioxin effect will be less. So potassium parenteral potassium KCl is the first treatment, IV KCl. And for ventricular arrhythmia, lidocaine is the drug of choice. For supraventricular arrhythmia, we can give propranolol, and for atrioventricular block or bradycardia, we can give atropine. And there is a dioxin antibody that is called DG bind, which can be given in severe cases. So first treatment is stop steroids, then give IV potassium chloride, so that sodium potassium ATPase channel gets less inhibited, and then we can give specific treatment according to the arrhythmia. If ventricular arrhythmia, we can give lignocaine. For supraventricular arrhythmia, we can give propranolol, and for AV block or bradycardia, we can give atropine. That is the anticholinergic drug we have read. Atropine 0.6 to 1.2 milligram. Propranolol is the beta blocker. Lignocaine is an antiarrhythmic drug. Also, it is a local anesthetic. Dioxin antibody. So contraindication of heart dioxin, we cannot use it in hypokalemia, because I have mentioned that hypokalemia will cause more dioxin inhibition of the sodium potassium ATPase channel. Renal impairment, because dioxin is eliminated renally, that's why dose should be reduced or better to be avoided. In myocardial infarction, dioxin must be avoided, because myocardial infarction or ischemic heart disease, patient already there is increased oxygen, there is less oxygen supply as per the demand. So dioxin, by increasing the heart rate or increasing the contractility, will cause further oxygen demand, and that will be detrimental for the patients of the myocardial infarction, because there we need to reduce the oxygen demand, but dioxin causes increased oxygen demand due to increased cardiac contractility. In hypothyroidism, dioxin metabolism is less. In myocarditis also, it cannot be used because of risk of the arrhythmia. Hypomagnesemia, hypercalcemia. So hypercalcemia will increase the dioxin effect, because more calcium will get entered into the cardiac myocyte, that will cause more actin myosin interaction and will cause further increased contractility and other effects. So hypokalemia, hypomagnesemia, and hypercalcemia, remember this, that will increase the dioxin effect. And ventricular fibrillation, it is contraindicated, but in atrial fibrillation, it is a very good drug. Patient must be advised not to take non-prescription cough or cold medications, antacids, laxatives, and in pregnancy, it should be avoided. So remember, hypokalemia, hypomagnesemia, and hypercalcemia, these are the contraindications of the dioxin. Now, with some diuretic, there is a hypokalemia, and that's why dioxin should be cautiously used with diuretics, especially thiazide diuretics. Thiazide diuretics has a unique property that though it causes hypokalemia, and it causes hypercalcemia also. So both, due to both reasons, the thiazide diuretics and dioxin better to be avoided together. So thiazide and dioxin should be avoided, because thiazide causes hypokalemia and hypercalcemia, and both that will both increase the risk of the adverse effect of the dioxin. These are the drug interactions: loop diuretics, thiazide diuretic, corticosteroid. They decrease the level of potassium, so there is enhanced digitalis cardiotoxicity, And also amiodarone, verapamil, they displace digitalis from protein binding sites. And next is digitalis effect is also decreased by some antacid sucralfate. There is due to reduced absorption, and enhanced metabolism of dioxin is done by some enzyme inducers like phenytoin, phenobarbital. So these are the drug interactions. There are lots of drug interactions of dioxin and lots of adverse effect of dioxin. So dioxin can cause any type of cardiac arrhythmia. That's why it should be avoided. It should be better to be kept as reserve drug. When patient symptoms are not controlled with other drug, then we can use. So diuretics we have discussed in diuretic class. They generally cause natriuresis and water removal. This leads to removal of the fluid, and that leads to relief of the congestion, and this will lead to decrease in the dyspnea because of relief of the pulmonary congestion. There is decreased peripheral edema, and ultimately there is decreased preload that will cause decreased workload on the heart. So high ceiling diuretics is preferred like furosemide, bumetanide. High ceiling diuretics are act principally on the ascending limb of loop of Henle, and they inhibit the sodium potassium 2 chloride channel, and they are high potency diuretics and effective even when there is renal insufficiency. So high ceiling diuretics, that means high ceiling means increasing the dose means increasing the effect, and that is we can increase the dose by many fold, and we can increase the we can have increased effect by many times. Suppose 20 milligram dose and 160 milligram dose, we can have 8 times effect. But for other drugs like thiazide diuretics or other diuretics, it is this high ceiling is not achieved, because thiazide diuretics after 25 milligram we cannot increase the dose, or actually dose increase actually do not have any extra benefit. So as in heart failure fluid congestion is more, if we can increase the loop diuretic dose, then that extra fluid can be eliminated. But for other diuretics like thiazide diuretics, even if we are increasing the dose, that extra fluid is not accumulated significantly. That means dose will not proportionately increase the effect. That's why high saline diuretics are preferred in the heart failure. IV furosemide promptly increases the systemic venous capacitance and produces rapid symptomatic relief in acute left ventricular failure. Adverse effects: acute fluid loss, hypotension, hypokalemia, hypomagnesemia, hyperuricemia, or toxicity. These are the common adverse effects of the all diuretics. It can cause hyperuricemia also, it can cause hyperglycemia also, and alteration of the lipid profile. But still, diuretics has that promptly causes salt and water restriction that will decrease the congestion rapidly. And for this high saline diuretics like furosemide, bumetanide used, another advantage is that even in patients of renal insufficiency, this is preferred over the thiazide, because if you remember the site of action of the thiazide and furosemide acts in the loop of Henle and thiazide acts in the further distal convoluted tubule. So in patients of renal failure, there is decreased GFR already, and during this decreased GFR, the drugs will reach to the distal tubule less. That's why in renal failure, thiazide activity is less, because most of the drugs cannot reach to the renal failure to the site of action. Whereas furosemide acts proximally, then drugs can reach even in presence of renal failure. So that's why this is the two. For these two reasons, furosemide is preferred over thiazide. One is it can cause it has high ceiling. That means increased dose will cause increased effect. That means it can lead to increased excretion of the salt and water. That's why it relieves the congestion better, as well as it is effective in the effective when renal perfusion is also less, because site of action is proximal to the relatively proximal to the thiazide. Proximal means it acts earlier. Thiazide, like diuretics, act principally on the early distal tubule, and out of moderate potency, it can become inefficient in presence of the renal insufficiency. So, cannot be used when GFR is less than 50 ml per minute, because thiazide cannot reach to the distal tubule or their site of action properly when GFR is low. Adverse effect is same, but remember thiazide are less effective diuretic in the heart failure. SC inhibitors we have discussed yesterday. So these drugs not only block conversion of angio-1 to angiotensin-2, but also prevent the breakdown of the bradykinin, and that will lead to vasodilation. They decrease the aldosterone secretion, so angiotensin-2 is not activated. That's why it will cause decreased aldosterone release from the zona glomerulosa, and hence reduce salt and water retention. So cardiac output is improved. They also cause natriuresis. They prolong survival by preventing the pathophysiological remodeling of the heart and blood vessels. So, due to less effect of the angiotensin 2 as well as less effect of the aldosterone, there is decrease in the cardiac, they prevent the cardiac remodeling of the heart and blood vessel. And most commonly used ACE inhibitor are enalapril, lisinopril, amipril. And adverse effect, hypotension of the first dose, as I mentioned, that is a vasodilator. So if patient remains standing after the take of the drug, then most of the blood will shift to the lower extremity, and that may cause dizziness or hypotension. And it can cause dry cough, angiolytic edema due to bradykinin effect. It is avoided in pregnancy because of risk of fetal malformation, and it's called hyperkalemia. So estimator for congestive cardiac failure, this is the, you have to remember this picture. It will cause decrease in the vasoconstriction, decrease in the peripheral vascular resistance, so also decrease in the aldosterone secretion, and decrease in the salt and water retention. So there is decrease in the blood pressure, and also due to bradykinin effect there is vasodilation, which will increase the peripheral circulation. So both due to decrease angiotensin 2 as well as decrease aldosterone release, and as well as due to increase bradykinin effect, there is significant vasodilation, increased peripheral perfusion, and also there is decreased salt and water retention. So that's why ACE inhibitors are used mainly due to its effect of prevention of remodeling. It is a life-saving drug, and also it will reduce the mortality in patients of the congestive cardiac failure. ARB, they stimulate the renin release and increase the circulating angiotensin 2 levels, result in increased amount of the angiotensin 2 now stimulate AT2 receptor, which are lying unblocked, causes vasodilation. So what does that mean? So angiotensin 2 ARB, they are blocking the AT1 receptor, and they block AT1 receptor means there is inhibition of the short loop negative feedback. That means normally AT1 receptor activation will cause decreased renin release, but as AT1 receptor is blocked, so there is reflex increase in the renin release due to loss of this negative feedback, and this renin will increase the level of the angiotensin 1, angiotensin 2, but this angiotensin 2 is now seeing that AT1 receptor is blocked, so they will now activate the AT2 receptor only, and that will cause vasodilation. So that's why, so main motto of the therapy of the heart failure is we have to promote vasodilation in different organs, so to increase the peripheral perfusion. And ACE inhibitor ARB both can cause peripheral perfusion because of their vasodilatory action. ACE inhibitor works better because ACE inhibitor has additional bradykinin effect because it decreases the metabolism of the bradykinin. Adverse effect is similar like ACE inhibitor. We cannot give it in pregnancy, cannot give it in hyperkalemia, also cannot give it in bilateral renal artery stenosis. Next, aldosterone antagonist, spironolactone, eplerenone. You can give, they enhance the diuresis by promoting sodium water excretion, but major effect is they prevent myocardial as well as vascular fibrosis, which is responsible for the pathological remodeling. So aldosterone antagonists also reduce the remodeling because aldosterone is responsible for this vascular and myocardial fibrosis, as well as angiotensin 2 effect is lost due to, as the angiotensin 2 also promotes the remodeling by causing extra release of the extracellular matrix as well as some hypertrophy of the vascular smooth muscle. Hyperkalemia is a major risk factor during therapy and requires sodium potassium monitoring. So if aldosterone antagonist and ACE inhibitor or ARB are given together, there is a further increased risk of hyperkalemia. We should monitor the potassium very frequently. And gynecomastia may occur in male patients after long-term use. Dose is 25 to 50 mg once daily. So gynecomastia happens because it will decrease the estrogen metabolism in male also, and that's why there is relative estrogen excess in the male that will cause gynecomastia. Aldosterone antagonist